Bismillahirrahmanirrahim. Assalamualaikum and good afternoon. Today I'll talk about clinical evidence of Baricitinib for treatment of COVID-19. So I think by now we already know about this. So the progression of COVID-19 is due to hyperinflammatory response. Thus, by giving immunomodulators such as steroid, interleukin inhibitors, or JAK2 inhibitors would benefits to curb the cytokine storm. So when we talk about immunomodulators, there's three types of, a lot of immunomodulators. One of it is corticosteroid. It's a very broad and potent anti-inflammatory. Because of broad action, it has a lot of side effects. However, it's cheap and widely available compared to monoclonal antibodies, in which it only inhibits single cytokine pathway. So it's able to avoid a lot of the side effects by corticosteroid. However, it's very expensive in UMMC. It costs about 4,000 for 70 kilos per person with limited availability. So there's something in between with the JAK inhibitors. It's offer a not too broad, not too narrow spectrum.
Can we change to this slideshow? Sorry, mata tak nampak orang tua.
Sorry. Is it slideshow?
Yeah, okay. Okay, perfect now. Go ahead.
Okay, so it's blocked on the cerebral cytokine pathway. It's not that broad as corticosteroid. Thus, it less side effect compared to corticosteroid. Compared to the cost, it's slightly cheaper for normal non-obese persons compared to tocilizumab. So what is Baricitinib? It's an oral JAK1 and JAK2 inhibitors, which is being approved for treatment of rheumatoid arthritis. So researchers have used artificial intelligence to predict the use of Baricitinib in COVID-19. So they had validated in vitro models, followed the success in 4 case pilot studies. So the mechanism of Baricitinib, basically it inhibits the intracellular signal pathway of cytokine and also had antiviral effect in which it prevents the virus entry to the cell. So is Baricitinib effective for treatment of COVID-19? Basically, I had done a kind of systemic review through PubMed, had found a lot of articles. Out of them, I found 2 RCTs, about 7 observational studies. So we start with a few prospective and retrospective studies first. First is by Cantini et al. Basically, it's a multi-center study comparing Baricitinib with Caletra and low molecular weight heparins compared to hydroxychloroquine and also the standard of care. So they're recruiting COVID-19 people with moderate pneumonia, which is, I would say, category 3, with mild to moderate ARDS. So in this study, they excluded corticosteroid. Patient on corticosteroid is not included. This is before recovery trials result. So basically, the baseline characteristics were compatible in 2 arms. There's improvement of the symptom with Baricitinib after week 1 or week 2 of Baricitinib started compared to hydroxychloroquine arm. Even biochemistry. The interesting about this is when Baricitinib added into the standard care of treatment, there's reduced ICU transfer or the need of ICU at 1 week or 2 weeks, and also reduced mortality. So this study showed that Baricitinib had reduced the mortality and also the reduced need of ICU, besides improvement in terms of the clinicals and also biochemical after week 1 and week 2. Next is Prontivi et al. Basically, is comparing Baricitinib compared standard of care, which is Caletra and also hydroxychloroquine. So as we can see here, with Baricitinib, is improve the CRP and also faster oxygen improvement can be seen after 4 days compared to there's no Baricitinib treatment. In terms of mortality, Baricitinib improve the mortality, but it's not associated with improvement in terms of ARDS incidence and also duration of hospital stay. Next, by Stabling et al., this is a cohort study in Italy. So they're comparing baricitinib versus standard of care, in which the standard of care is a concomitant antiviral therapy and also hydroxychloroquine, Kaletra, antibiotic, corticosteroid, and also low molecular weight heparin. So in this study, baricitinib had showed significant in terms of reducing the need of invasive mechanical ventilations or mortality with the hazard ratio of 0.29, and it is really significant. Next, by Falcon et al. Basically, the study is initially to study the effect of low molecular weight heparin, but they also included patients on baricitinib, in which baricitinib given at dose with mild to moderate ARDS, I would say it's category 3, category 4 and above, if we're using our Malaysian category. So here we saw in the multivariate analysis, only low molecular weight heparin associated with reduced mortality, but steroid and baricitinib is not associated with reduced risk of mortality, while steroid and low molecular weight heparin associated with reduced mortality and also severe ARDS in such patients. Next, by Rodriguez et al., in which they included patients with moderate to severe COVID-19 pneumonia. So in this study, they're comparing corticosteroid and baricitinib versus Kaletra, hydroxychloroquine, and also corticosteroid. So their standard of care consists of Kaletra, hydroxychloroquine, and if patient with respiratory failure, they may give IVIG or interferons, and some pulse with methylprednisolone or other medication. So by giving baricitinib is not associated with mortality, increased rate of mortality or ICU admission compared to standard of care corticosteroid. However, baricitinib arm showed reduced need of oxygen at discharge and also even at 1 month of discharge. There's more people discharged without requiring oxygen even after a month or on discharge. So basically, baricitinib with without remdesivir is an alternative for treatment of COVID-19 if corticosteroid is contraindicated. However, remdesivir is not available in Malaysia. Can we use baricitinib alone? And is there any clinical benefit adding baricitinib with corticosteroid or tocilizumab? So there's 2 randomized control trials to answer our question. First is by Khalil et al. In ACTT2 trials. Basically, it's an RCTs comparing remdesivir plus baricitinib versus remdesivir and also placebo. They included WHO Ordinal Scale 4, which is equivalent to our category 4, or dose requiring oxygen. Sorry, WHO, which is dose with pneumonia or requiring oxygen, and even dose intubated or requiring ECMO. In this study, they not included patients on corticosteroid except if they have indication, for example, acute exacerbation of asthma or adrenal insufficiency. Most of the patients included in the studies, I would say, category 4, hospitalized with requiring oxygen. More than 50% of them in that category. Baricitinib had associated with shorter time to recover by 1 day, and this is more pronounced when we see dose requiring high flow oxygenation, in which ordinal score of 6. However, it's not associated with reduced mortality, in which there's no significant difference between placebo arm and also baricitinib. Baricitinib also showed able to reduce the hypoxemia progression to hypoxemia by 17%, but not hospitalization stay. It also associated with reduced need of invasive mechanical ventilations or ECMO by 5%. Next, in cough barrier study, in which they're comparing baricitinib versus standard of care and also placebo versus standard of care. About 80% of the patients of the participants on corticosteroid, they included those who are category 3, our cat 3 with evidence of inflammatory, hyperinflammatory response. So basically the demographic is quite similar in both placebo and also baricitinib arm. We can see baricitinib usually started at day 7 and above, and most of the participants are, I would say, is category 4. And patients who are intubated or ECMO were contraindicated in this study. This study showed a significant improvement in terms of the mortality, with number needed to treat is about 20. We only need to treat 20 patients to reduce one mortality in patients treated with baricitinib. However, it's failed to show the superiority in terms of the primary outcome, in which the progress to high flow oxygen and IV or mortality. There's no difference in terms of number of ventilator-free days, hospitalization, also median time to recover. So the overall mortality is significantly improved, with number needed to treat of 20, and it's more pronounced in those with require high flow oxygenation before they intubated, with hazard ratio of 0.52. There's another observational study, which is a small study comparing baricitinib or tocilizumab in COVID-19, in which they recruited those with interstitial pneumonia with moderate, mild to moderate ARDS. Most of the study, they have bari monotherapy plus corticosteroid, about 92%, toci plus steroid, bari and toci plus steroid, and without baricitinib or tocilizumab. Basically, there's no significant difference in terms of the mortality of each arm. So bari, toci had similar efficacy in terms of reduction of the mortality. So this is the summary. So there's two RCT showed that baricitinib had improved in terms of the mortality added with tocilizumab, and also progression to hypoxemia. And there's other studies also showed a very good outcome with baricitinib. In terms of safety outcome, for treatment of baricitinib, for long-term use of baricitinib in RA is associated with mild side effects such as URTI, GI symptoms. It also associated with infection, some cytopenia, GI disturbance, cardiovascular, and also high CK. So I had summarized into this table in which there's no alarming evidence of usage of baricitinib for COVID-19 associated with increased risk of cytopenia, thrombosis, infections, transaminitis, or other side effects, except if using a higher dose or loading dose of baricitinib, in which it's associated with thrombocytosis and higher evidence of mild ulcer by Hassan MJ et al. So now it's come to discussions. So when we want to use baricitinib, any roles of baricitinib in intubated patient, because the study, the two study, although the ACT22 study included this on intubation, but we see the improvements on if they're not intubated or on ECMO. If there's because we know COVID-19 is associated with venous thromboembolism.
Hello.
Mm-hmm.
Hello.
Yes. Hello.
It's okay. Go ahead. Sazali, go ahead.
Okay. So, if we know COVID-19 is with high risk of VTE. So, in the presence of VTE or suspicion of VTE, should we use or continue using baricitinib? And when to use baricitinib versus tocilizumab? This is something that I think we should discuss, so that we kind of have a national consensus when to use so that we can, I don't know. Yeah.
So, Sazali, I thought we were going to give answers for all those questions.
On the way.
So maybe we should start with the case discussion, and see then what other people think about it. Basically, we are.
Just a minute, Sazali. Who is NK? Can you mute yourself? NK, please mute yourself. Okay, fine. Go ahead. Yeah.
Okay, this is the NIH guideline of management of COVID-19. They recommended using either Baricitinib or tocilizumab in combination of dexamethasone plus or without remdesivir for patients on high flow oxygen or non-invasive mechanical ventilator. But there's no evidence for those who are intubated. And yeah. So usually we're giving Baricitinib, the dose is 4 milligrams daily for 14 days or till discharge, which one is earlier. This is the adjusted dose of the Baricitinib. So I'll share short experience of UMMC for few patients, and I think Lim will continue sharing their experience in Sungai Buloh. So basically, we have a 63 years old gentleman who with uncontrolled diabetes. He presented at day 3 of illness with fever and shortness of breath. He was on category 3 on admissions. However, next day he desaturated, in which we started dexamethasone 6 milligram. However, next day he further desaturated, very rapid increasing oxygenation until require high flow nasal cannula. So CRP also, is very high during that time, and we decided to start Baricitinib renal adjusted 1 milligram daily. So then the renal improved, we increased the Baricitinib dosage. Patients kind of static, but doesn't require intubations. ICU also had presumptively treated with hospital-acquired pneumonia for this patient with tazocines. Then we can see the progress. The CRP we can see the improvement in the CRP after day 4, day 5 of Baricitinib. Then patient continue to improve and doesn't require further, invasive mechanical ventilations. Our next patient presented at day 6. She's a morbid obesity. However, no desaturation because as category 3, we only started DVT prophylaxis. Young with obesity. After 3 days, she desaturated, and 2 days later, increasing further the oxygenation, in which we requiring Bari. So CRP also kind of jump at day 10 of illness. Then with Baricitinib, we can see the CRP, there's no much CRP improvement during the first few days. Only after day 4 of Baricitinib, the CRP coming down, and then patient continued to improve after that. Our third patient, 67 years old, with diabetes, also history of some operations, was presented at day, sorry, I forgot to put the, about day 5 of illness, that desaturated in NMAIP and transferred to us, started of dexamethasone. However, 3 days in our hospital, further deteriorated, increasing oxygenation. CRP also is not much improvement despite dexamethasone, in which we decided to give Bari. After 4 days of Baricitinib, she developed transaminitis, in which we need to withhold the Baricitinib. However, the CRP is slightly increased because of some infections, but patients continued to improve and finally managed to off the oxygenation after about a week in the hospital. I think that's all for me. Maybe I'll pass to Lim.
A very good afternoon, Lim Casey here. Can you all see my slides?
Yes.
Okay, so Sungai Buloh started to use Baricitinib. The first patient was given Baricitinib on the 16th of June, so we have limited experience only, about 2 weeks. So out of the first cohort, about 8 patients, I will share 2 cases here. So the first patient is a Mr. JB, is a 48 years old gentleman with a BMI of 26, no previous comorbid, was admitted on the 13th of June. The diagnosis upon admission was COVID-19 pneumonia, day 9 of illness, category 4, requiring a face mask 5 liter with hyperinflammatory hypoxia, CRP of 6.7, and you can see the X-ray here. There's a GGO, especially at the peripheral distribution. So the initial treatment given was metapred 2 mg per kilo, as well as the enoxaparin. So at your leftmost column here, this is the first day data. So it came in with the face mask 5 liter, CRP 6.7 as mentioned. So if you could see after second day, the CRP slightly improved, that the face mask.
Sorry, can you explain your CRP values?
I'm sorry, our below CRP value is milligram per deciliter. So in other center, most of which is using milligram per liter. So it will be equivalent to 67 in other centers. Okay, so you need to times 10. Okay, so so for the first 3 days of metapred, the oxygen remains static at face mask 5 liter, but it seems there's a slight improvement in terms of CRP. But patient had a deterioration occur despite after 3 days of metapred. On day 4 of metapred, which is day 12 of illness, the oxygen requirement increased to 8 liters, CRP rebound to 89. And so at that time, they decided, because at the same time, if you see the next slide on the day 12 illness, the X-ray is also worsening. So based on deterioration in terms of oxygenation, CRP and chest X-ray, so the decision to add on Baricitinib was made that time. Of course, at the same time, invariably, we can't rule out bacterial co-infection. Culture PCT was taken, Irosafin was started, and PCT that time was 0.34. So this is the X-ray I show on admission as compared to the time of deterioration to face mask 8 liter with rebound CRP. So 1 day after Bari, patient continued to deteriorate, and actually we observed the same pattern as in of which Baricitinib take about 3 to 4 days. For the fastest is 48 to 72 hours for the patient to have a response in terms of CRP. As you can see, after only day 4 of the Baricitinib, then we can clearly see a reducing trend of CRP, and as well as a reduction in the high flow mass from 15 liters to 12 liters. Subsequently, bug culture will no grow, so we completed Rosafin 5 days. Then we continue with the Baricitinib. Then you can see, but X-ray changes might lag behind, but there's no further worsening of the chest X-ray changes. Then patient continued to improve actually in terms of oxygenation, just that on day 18 of illness, there's slight rebound in CRP, again from 74 to 96. Repeated procal remain low at 0.2. That time did a HRCT scan which show COVID-19 with features of OP with total lung involvement more than 79%. Hence the decision to give another 2-day short course of 2 mg per kilo metapred here, and subsequently patient improved further. So this is just to show the CT scan HRCT. As you can see, there's a lot of GGO and both a central and peripheral distribution, as well as the perilobular density. Otherwise, there's no other remarkable changes, and it's worse at the lower zone as commonly seen in COVID. So patient continued to improve, became room air, CRP was low 22, so steroid change to prednisolone, tapering 5 mg every 5 days, and eventually patient was completed Baricitinib day 13. This is the X-ray upon admission. Yeah, it still look bad, but then the patient clinically improved, CRP improved, so we discharged with a TCA 2 weeks. So in summary, in our first case, so is a gentleman who is admitted on the day 9 of illness with hyperinflammatory hypoxia, then CRP rebound on day 4 of metapred, worsened both oxygen, chest X-ray, CRP. That at that point, Baricitinib, Rosafin was started. Hindsight, culture no growth, PCT 0.34. It took about 3 to 4 days, 3 days usually after initiating Baricitinib treatment before seeing a response in CRP and oxygenation. In this case, patient had another small rebound in CRP on day 18 of illness, but without concomitant deterioration oxygenation, given 2 days of metapred in between before switching to prednisolone 0.5 milligram per kilo per day. And he was discharged well on day 24 of illness, and by that point, he already completed Bari for 13 days. Then we go to the second case. Second case is a Mr. CKC. It's a 62 years old gentleman with the underlying hypertension on telmisartan. He was admitted on the 12th of June with the diagnosis upon admission is COVID-19 pneumonia, day 8 of illness. Again, hyperinflammatory hypoxia requiring nasal prong and CRP of 6.6. And this is the X-ray on admission. He was given Dexa 12 milligram. In addition to that, Claxin and Favi. He is a transfer-in case from MAIS. The Favi actually, in fact, already started there for 3 days upon transfer to Sungai Buloh. So he initially showed improvement in terms of CRP after about 3 days of Dexa. Subsequently, there's an increasing of CRP. There's no worsening trend of the nasal prong. So we added on Rocephin, but then with cultures, but we hold on, we didn't escalate the Dexa because there's no deterioration in terms of oxygenation status. However, on day 14 of illness, as you can see here, the oxygen patient deteriorated from nasal prong 3 liter become high flow mass 15 liter, and the CRP jump up from 41 become 181. The procal that time was 0.17 only. There's clearly evidence of hyperinflammation as evidenced by the high ferritin and D-dimer. So was escalated to metapred. Then patient actually slightly improved with metapred. Actually, patient improved with metapred. That shows the X-ray got new GGO worsening. Patient actually improved with metapred. So deteriorated on day 14, started metapred, improved with metapred from high flow mass 15 liter to 10 liter, but he had then CRP reduced from 180 just now to 74. And he had another deterioration on day 18 of illness with the rebound CRP and the rebound increase in the oxygen requirement to high flow mass with 15 liter back. That's occurred despite in the presence of metapred. So again, at that point, Baricitinib was started, Cefepime was started as well. And again, we talk about, so this is an X-ray. As you can see, the lower zone, the GGO looks more dense as compared to the one on admission. And this is a CT done, which actually, again, show patchy GGO, again, the central and peri distribution, and the basal collapse consolidation as well. And okay, so metapred was metapred after the second deterioration. So metapred and Baricitinib was started. Subsequently, procal came back to below 0.08, culture no-go, Cefepime were off. Then subsequently, after the addition of Baricitinib, patient responded continuously, improvement in oxygen and CRP. Patient currently is still with us in our rehab ward in the MDSU. On nasal prong with the tapering prednisolone, and Baricitinib was off after 7 days. Okay, after the CRP has become very low, 12. So in summary of the second case, so this gentleman admitted on day 8 of illness with hyperinflammatory hypoxia, CRP of 68. On day 14 of illness, he deteriorated from nasal prong to high flow mass with rebound CRP. That time the deterioration happened in the background of dexamethasone, so the decision of escalation to metapred 2 milligram per kilo. Initially slightly improved for 3 to 4 days. Another deterioration on day 18 of illness where the oxygen is back to high flow mass again from base mass 10 liters, CRP increased to 100 again. In the presence of a day 5 of metapred, hence the decision to adding a Baricitinib and Cefepime. Hindsight, there's no strong evidence of sepsis and patient clinically not septic, and after addition of those treatment, patient improved, and now on nasal prong CRP already rock bottom about 12, and on tapering prednisolone now. So these are the two highlights of the cases that we see. But of course, the $1 million question is, when should we give Baricitinib? Just in my humble opinion, I think in terms of pathophysiology, how it works is a JAK1 and 2 inhibitor. Patient must have evidence of hyperinflammation to begin with. And patient can be admitted if high flow mass oxygen support with or worsening face mask oxygen support despite steroid therapy. And X-ray must have worsening despite on steroid therapy, or at the beginning already very bad on multilobular involvement. That most importantly, we must rule out bacterial sepsis before considering adding an immunomodulator agent. Okay. Thank you.
Hi everyone, Assalamualaikum. So I'll be talking about new options of treatment in COVID. Basically, I'll go through two papers. Okay. So as introduction, Regeneron is actually a monoclonal antibody. Basically, it has high specificity and it has been used in other previous viral diseases like RSV and treatment. So it's quite in Ebola, and it is quite safe. So how it works, it binds to the spike protein of the virus, thus blocks the entry to the host cells. So there are a lot of papers, trials, ongoing trials, some of them using monotherapy and monoclonal antibodies, some of them using combination. So the one that we are looking at, the dual combination is casirivimab and imdevimab. It's an IV cocktail of two monoclonal antibody. So these are the first paper which focus on the use of REGEN-COV in outpatients. So this is actually an interim analysis. It is ongoing phase 3 trials, and they do this interim analysis when the samples at the 275. So what they did is they divide into 3 arms. Each is 1:1:1 ratios. One arm receiving placebo, one arm receiving low dose of REGEN-COV, which is 2.4 gram. One arm is in a higher dose, which is given 8 gram. So what they are looking at, number 1, cessation of symptoms. Number 2, reduction in viral load. Number 3 is the outcome of patient needing hospital visits at day 29. So as you can see, the demographics are propensity match, median age group in a younger group around 40s. And they did a baseline antibody at randomization. So 45% are seronegative, 40% are seropositive, and 15% is unknown. So what they can conclude is those with seronegative, they have the higher viral load, which is log 7, compared to seropositive, where the viral load is log 3. And the mean symptoms before randomization, before they start giving, they randomize these people into those arms at 3.5 days of onset. So what they can see, the outcome is time to elevation of symptoms. Those receiving placebo, it took them 9 days to alleviate the symptoms, compared to those in treatment group. For low dose of REGEN-COV, it took about 6 days. For those with a high dose of REGEN-COV, it took about 8 days. And those with seronegative group, those in placebo seronegative took about 13 days to alleviate the symptoms. And those in treatment group is about half of that. It's about 6 to 8 days of them to alleviate the symptoms. So it is very significant in seronegative group. So this graph shows the baseline of viral load. As you can see, so where's my, right. As you can see, these are those with the lower viral load, log 10 to the power of 4, and the most right is log 10 to the power of 7. So this group has the highest viral load. After about day 3, post-randomization, post-treatment, you can see the viral load has reduced remarkably from 7.5 to 4.5, and at day 7 of randomization, it goes down, the viral load goes down to half of it. So it shows that this cocktail give a very remarkable impact to those with higher viral load at randomization. If you look at the most left of the chart, this is at the those with the lower viral load at 10 to the power of 4 copies. After 3 days, the reduction is not as steep as this group. Okay. And in terms of outcome in patient needing hospitalization at day 29, in placebo group, about 15% of the patient needs to come back to the hospital compared to the treatment group. For those with given lower dose of the cocktail, 4.9%, those with a higher cocktail, 7.7%. So in overall treatment group, 6.3% of patients has to come back compared to placebo group, 15% of them needs to come back. So then some may ask how long this monoclonal antibody lasts. So they look at the patient's serum level at around day 28 or day 30. The serum level is still high, so which means it can last up to about 1 month after the first dose given. So from that interim analysis comes to this recovery regen trial. So this is a randomized control open label trial which done at 127 UK hospital. So what they want to see is they divided into 2 arms, standard care alone plus standard care with IV RegenCough. But in this study, they give a higher dose. Previous study, the outpatient one, they divided into 2 mild, lower dose and higher dose. For this paper, they give higher dose straight away, which consists of 4 grams of casirivimab and 4 grams of indivimab. So they want to see the 28-day mortality in seronegative patient and then compared with the overall patient. During this study was done, at that time, from December to April in UK, the dominant variant is alpha variant. So it shows that this cocktail seems to be working on alpha variants. There are some papers found that there are mutations in beta and delta variant, but because of this cocktail contains of 2 different monoclonal antibody, this can reduce reduction of neutralization, meaning it still can be work on beta and delta variant. So this is how they divided into 2 arms. One is RegenCough cocktail, one is a standard care alone. So the sample numbers are quite huge, for about almost 5,000 in each arm. So these are the baseline demographics compared to the outpatient study. This patient's age group is a bit older. It is in 63 to 64 years old. Again, it's propensity match in both arms. So they divided into seronegative because their aim is to see 28 days mortality in seronegative patient compared to all patients regardless antibody status. So they give to the patient that needs, majority of them needs only nasopron to face mask, so simple oxygen. 66% of them upon randomization needing low dose of oxygen, 20% needing NIV, and about only 2% needing invasive ventilation. All right, so from the whole sample, 1,600 are seronegative, and the rest of them 2,600 are seropositive. And majority of them, of course, already have a steroids treatment ongoing. So these are the outcomes that they want to see. In 28 days mortality, those with the treated group shows reduction in mortality percentage, which is only 24%, compared to the standard care is about 30%. And okay, let's look at this graph. Seronegative versus seropositive. So the first, the upper one is seronegative, the lower one is seropositive. So as you can see, the mortality rate in seronegative group, those treated with Regen cocktail reduced about 24% compared to 30% seronegative standard care group. But if you look at the seropositive arm, the mortality, seropositive patients, the mortality of both arms does not differ much. So it shows that it works more in those seronegative group. And again, when you see at the whole participant, despite seronegative or seropositive, the mortality does not differ that much. So these are the forest plot. The three outcomes that they want to see in the treated group, which they divided into seronegative and seropositive, or the standard care arm, again divided by seronegative and seropositive. So the death within 28 days, as I mentioned, in seronegative group, it has some reduction, 24% compared to 30%. As compared to seropositive, the death is about the same in both arms. In terms of outcome of discharge from the hospital, the seronegative group has, with the Regen cocktail, has a higher percentage of being discharged compared to the usual care. But again, if you look at the seropositive group, the numbers are the same. The outcome is the same. In terms of the patient needing invasive ventilation or leads to death, again, in seronegative shows a better outcome. Only 30% of them needing ventilation or resulted to death compared to the usual care. And in seropositive group, both arms has no difference. So yeah, this is again the highlighted, the death again, significant reduction in seronegative group. The discharge alive in seronegative group is higher, and most of them are discharged within 13 days compared to 17 days in usual care group. And in terms of needing invasive, the seronegative group treated with Regen has a lower risk to progress to invasive ventilation. So in terms of safety profile, so they look at after 72 hours of randomization, basically it's only had a low grade of hypersensitivity reaction. 4% of them has fever and hypotension episode, and 2% have thrombotic event. However, they did not specify which kind of thrombotic event. So for conclusion, I think this cocktail of monoclonal antibody has impact in those seronegative patients. And then it increased the rate of discharge and reduced the progression to ventilated. But the thing is, when they did the trial, at randomization, they did this antibody using high-end lab rather than POCT type of antibody. So I think that's the limitation if we want to use it to apply it here. But I think this treatment cocktail is promising in a seronegative group. Yeah. So that's all for me.